Welcome back to another episode of Oncology for the Inquisitive Mind, and a very special episode. I'm Michael, that's Josh, but you don't really care about that because we have a very, very special guest. Coming from the UK, we have Professor Jenny Seligmann, who is a consultant medical oncologist and senior lecturer in Leeds in the northeast of England at St James's University Hospital. She is a member of the Advanced and Adjuvant Disease Subgroup, a lead researcher in the FOxTROT program, which we'll talk about in a moment, and has authored over 60, I'm sure that's a little bit of an understatement, professional publications with a special focus on bowel cancer. Jenny, we are so glad to have you on. Thank you so much for giving up some of your time.
Thank you for the invitation.
We've been looking forward to this for a long time, but we do like to give listeners a bit of a background because we are a people-focused podcast. And so we just want to get a bit of your story. Josh likes to call it the origin story, the superhero origin story, about your journey into medicine and what made you choose medical oncology, because it's not necessarily a specialty that people who are not in medicine or just starting their medical journey want to go into as cardiology or something like that. So what set you on the path?
Just a wee bit about me and my background. So I'm from Edinburgh, which is in Scotland, for those people who wouldn't know. I decided I wanted to do medicine at quite an early age. And through medical school, I did an extra year research degree. I was really just interested in internal medicine. I am not dexterous. I cannot do things like sew a button onto a shirt. And so surgery was ruled out at a very early point. But I was always interested in gastrointestinal disease. But again, scoping and surgery was never going to be for me. And a lot of people have said, why medical oncology? I am a big believer in what I would say finding your tribe. So you find the people who are most like you. And I went through all the medical specialties. And actually, the first time that I thought, right, this is where I belong, was actually in medical oncology. It was a really interesting group of people, very compassionate people. But on the other hand, people who made decisions, people that were comfortable in, I suppose, not looking after just one very specific area of the body. But we do a lot of general medicine in patients with cancer, and that really appealed to me. And in particular, gastrointestinal cancer, I was always kind of led towards GI disease in general. For me, it was just a great fit. But for me, it was the department, the people and the research and just finding the place that I belonged.
Mark and I always remark it's hard to find an oncologist that's not a nice person. You have to be pretty compassionate in this role. Most of the people. You found your tribe, which is fantastic in colorectal cancer. But, you've sort of gone one step further, which is not just treating colorectal cancer, huge number of publications, your translational, passions. And I trained in a regional town far away from where I live now. And the whole idea of becoming like a translational oncologist or a clinician scientist was just so far-fetched. I would love to talk about how you yes, colorectal cancer, but then you're like, let's do papers, let's figure out A equals B. Was there something within the colorectal world that sparked your interest and still does today? Or is it just want to make that overall survival curve look a little bit better?
I've got to be really honest with you here. I didn't jump out of the womb thinking, right, I want to be a translational oncologist. And a lot of things that have happened in my career have somewhat been a degree of serendipity. What's helpful to think about is what kind of a job that you want. So number one, I was drawn towards academic oncology because I needed to do something other than a 9 to 5, which some people are so great at. But for me, I was looking for greater variety in my job. So that doesn't need to be academia. That can be teaching. That can be, management and looking after people. But for me, I needed something else. I had a very serendipitous first attachment in medical oncology. It was with the gastrointestinal team, and it was with my mentor, who is Professor Matt Seymour. He's just recently retired. And Matt Seymour was the person behind some of the major landmark trials in colorectal cancer. So the FOCUS trial, where they tested the very first trial to test upfront irinotecan versus oxaliplatin. And it was a really great environment. He was linked to a translational group with Professor Phil Quirk, who again is one of the major leaders in pathology. And so I was very lucky to be in that environment, but really I didn't fall into that environment. I got on very well with Matt and I worked hard and was really interested and I asked the right questions and I had the background. So I had done a research degree before. And so when I was looking for a PhD, it was a really perfect fit for both of us. He was looking for a PhD student, but I was really interested. So sometimes I think, look, you're at the right place at the right time, but you have to be the right person at the right place at the right time and make the most of the opportunities that are presented to you. And in most people's centres, there are such opportunities. It's just making sure that you are the person that is considered for such an opportunity. Really, it's really inspiring to see world-leading research being done by somebody who's in an office 2 doors down the corridor from you and who you're seeing with patients on a ward round. And the fact that people who you work with can then influence worldwide practice was really exciting to me. It didn't occur to me that I would then be able to start to be on the road to do that myself. But just the fact that you could influence management of somebody in a different continent by working in your office within your team, I mean, that's hugely inspiring. And Matt just made it very accessible. I was very lucky that he gave me all the opportunities. He didn't have a lot of ego. And I think that's something that I need to remember always going through, to just remember people coming through and just try to inspire them and make sure that you know that you can influence worldwide practice from your office.
That's fantastic and words to live by. Just before we get into the colorectal space, Jenny, I just wanted to make a note for some of our UK listeners about the CRC STARS initiative, which among your many hats you're heading up. This is a £5 million fund to form a world-leading research team that is tasked with making personalised medicine a reality for people with bowel cancer. How did that all come about? How did you get involved? And what can practitioners in the NHS in the UK, what can they look forward to from this program?
For me personally, this is a very welcome route back to the bench. So I did my PhD on biomarkers in the pathology lab, and I've very much since then been a clinical trialist. We might talk a little bit later about our ARIEL trial and how bench to bedside and then back to bench is just the perfect model for moving things forward in oncology. And so this is the perfect example of how you can then start thinking about, well, what's going to be the next question in 5 years? So from the original FOxTROT trial, we have a really unique biobank. So we have pre and post treatment samples. And that's quite rare in colon cancer because you usually just have pre-treatment samples. And so CRC STARS is giving a really unique opportunity to understand what happens to tumours under the stress of chemotherapy. And we have a radiotherapy arm as well. So it was a couple of phone calls from some of our lead scientists. So Owen Sampson's the CR UK director in Glasgow, and Simon Leedham is a leading gastroenterology researcher in Oxford. And I had samples and I had questions, and they had some really fantastic collaborators and models and the ability to look at serial samples and understand what happens, to try and understand why some people get relapses and some people don't, and what happens to the tumour itself in patients who respond and patients who don't respond. And so I suppose the ultimate goal is trying to, number one, understand potential biomarkers at the outset, but number two, try to understand what pressures the non-responders are under to try and see if there's novel strategies for them. So it's a big consortium. I think there's about 60 co-applicants in the end. It's a big effort all across the UK, but also involving researchers in Val d'Hebron. So yeah, we're really grateful to CR UK for believing in us and really investing a really phenomenal amount of money to allow us to really exploit the biobanks that have been created in clinical trials.
And what a noble pursuit. I think if I had $1 for every time a patient went to me, why has this happened? What can we do? What's the biomarker? I'm like, probably wouldn't be working. I'd be a very, very wealthy man. But you did mention the ARIEL trial, and we love to kind of bounce Jenny off sort of what you're doing. So you might just sort of pivot that way. And I think it's sort of a nice sort of segue from what you've actually just said. So, we have these drugs. And the nice thing, I'm not a colorectal cancer specialist, but I do like covering it because things don't change that much every year, which is good and bad, right? So the ARIEL trial is essentially looking to see whether or not, cetuximab or panitumumab would work in a broader cohort of individuals. Would you mind talking a little bit more about this project, which you're obviously involved in, and sort of what the aims of it are?
Yeah, but I'm going to correct you firstly. So colorectal cancer is now a really exciting area to be working in. We've been like the poor sibling of melanoma and lung. We've been watching all of these lung and melanoma people with all their Kaplan-Meier curves and all their biomarkers. And actually, in my opinion, in the next 5 years, colorectal cancer is going to be where it is at. We've got new biomarkers, we've got new targets, we've got new treatment windows. And so it's going to be a really exciting place to be. So I'll just make that very clear.
Maybe I should switch my subspecialty area, but either way, Jenny.
Josh, you stepped in it bad there.
That's why I never do anything in the evenings, because I just don't have any frontal lobe. But look, either way, Jenny, I am curious about this trial.
Back to ARIEL. So this is the perfect example of how you can start out doing something and then 10 years later. So my actual PhD, so this is going back to 2012, my PhD was looking at biomarkers of EGFR sensitivity. And this was just at the point that BRAF and PIK3CA were all just being looked at. So we had, some early data about RAS, BRAF. It was just the dawn of personalised medicine. So again, right place at the right time. And we looked at not only the DNA markers, but also looked at the RNA markers, because EGFR in colorectal cancers are a really difficult target because overexpression is very difficult. Looking at the mutations in lung, it's not the same. So what we can do is you can measure the ligands of EGFR rather than EGFR itself. So in my PhD, I saw two markers, epiregulin and amphiregulin, and found out that high expression of them was associated with panitumumab benefit, which I suppose is not surprising because it tells you that the driver of the tumour is through the EGFR. So that's kind of obvious. What's happened since then? So that was in my PhD and we published that. And then our next PhD student then looked at it in IHC, and we had a big project with Roche Diagnostics to then develop a clinically usable marker. Then again, right place at the right time. So in all comers, the drug companies weren't terribly interested in limiting the number of patients that they wanted to treat. But at the same time, it became obvious that right-sided colon cancers didn't respond to EGFR agents, whereas left did. And then all the guidelines changed. And suddenly there was this pool of BRAF wild-type patients that weren't getting panitumumab or cetuximab. And actually, I thought to myself, you know what, right and left, that's a bit of a blunt tool. I bet you epiregulin and amphiregulin would be better. And right enough, we went back to the data set and we found that there was a group of patients who had right-sided tumours who appeared to still benefit from panitumumab, who had high AREG and EREG. So we looked at that retrospectively. And of course, the next bit is to then look at it prospectively. And that's where the ARIEL trial came about. And so the ARIEL trial is a really simple trial. It's comparing standard of care, first-line treatment in metastatic right-sided colon cancer compared with adding EGFR. So that was funded by the NIHR in the UK. It's about 10 to 12% of the entire metastatic colorectal cancer population. And we've recently just got funding to roll it out to Italy, Germany, and Spain, with Roche Diagnostics doing the prospective biomarker testing. We really hope that this is going to, number one, be an option for these patients who really have very few options because they can't have EGFR. And we will see what it shows. Fingers crossed for them.
It's really interesting. And this whole idea of a right side and left side of being a continuum as opposed to sort of this arbitrary cutoff, which no one can really agree where it is. Is it the middle of the transverse colon? Is it the splenic flexure? Where is it? And therefore sort of having, as you say, a population of patients that are more, to our minds, more left-sided, even though they're on the right-sided, to use very sort of crude language, is very interesting. I guess the other part of EGFR and the study that I know you're involved in that I wanted to talk about is what happens after. I mean, Josh and I talk about when there's new agents and agents that are being used in new ways. We say, great, but what happens after patients progress? And so there's the Origami 3 trial, which is looking at amivantamab, which is getting a lot of very positive press in the lung space. What is it about amivantamab, do you think, if you have any idea, or EGFR itself, that leads to resistance? Is it sort of the activation of acquired KRAS, NRAS mutations, those sorts of things? What is it about amivantamab that might overcome that?
We have really nice studies in RAS and RAF wild-type patients. So the interest in that group of patients is re-challenge. So can you then use EGFR agents again after a treatment-free period? And what there is really nice ctDNA studies which track patients through progression And what you can see very clearly is that you're absolutely right. They acquire mutations. So they require mutations in KRAS, NRAS, and EGFR ectodomain mutations as well. And you can see them increasing, and that is associated with clinical resistance, which of course makes sense. But what can happen is that over time, these decline. And for a subset of patients who then revert to being RAS-RAF wild type, actually you can retreat them. So that's a really hot topic in colorectal cancer at the moment. And ASCO and ESMO GI, there was about 4 studies that were presented suggesting that you can go back in and treat these patients, but you can only treat the patients that are truly wild type again. Some patients won't convert and they'll remain resistant. So going back to amivantamab, so it's a EGFR MET bispecific. So MET is an important part of the pathway, and I don't think we've ever really understood the interactions with MET. I have to say we will see. And of course, there's Origami 1, which has looked at, there was different arms of Origami 1 giving some initial efficacy data, which you're right, looked promising. It also looked at re-challenge. So it looked at amivantamab in the re-challenge setting, which for me makes a lot of sense. We have Origami 2, which is looking at amivantamab head-to-head against standard of care, which would be considered as your standard EGFR agents or bevacizumab. But you're right, Origami 3 is looking at second line. So in some regions, that's going to be easier than others. Certainly in Europe, we would be treating RAS-RAF wild-type patients with anti-EGFR in the first line. It would be quite unusual. But in the States, there's still quite a lot of people that give bevacizumab first up. So it will be interesting to see the regions that recruit to Origami 2 versus Origami 3, first line versus second line. The trial population that goes into ARIEL, you're right, some of those may well end up in Origami 3. So the right-sided RAS-RAF wild-type patients who maybe have had bevacizumab in the first line go into Origami 3. And again, I think we're all interested to see how this EGFR MET. But the one thing that is very clear is what has happened in lung doesn't necessarily happen with colorectal cancer. And the same with melanoma and BRAF, in case you don't know. So to target BRAF in colorectal cancer, you need to add an anti-EGFR. The stories that have been relatively simple in other cancers just have never been quite as simple in colorectal. So we wait with interest.
I also just want to ask about something that you mentioned there, Jenny. You mentioned that acquired mutations can then regress. In my very simple-minded way, I'm thinking sort of, we're stressing these cancers with these agents and they're changing. Do they almost need a break? So do you need to treat them, say, you go from an anti-EGFR to Bev, and then it's sort of third line, and that's when you check whether they've lost that? I would imagine you can't keep hitting them.
So that's exactly the point. And again, that's another area of increasing interest is sequencing. Now, this is something like 5 years ago, 10 years ago, this was not a problem for colorectal cancer because we didn't have enough agents to sequence, quite honestly. But actually, particularly in the refractory setting, we've got Lonsurf plus bevacizumab. So the Sunlight trial, that's very much the established third line option in colorectal cancer. So the question that Origami 1 trial actually showed at ESMO GI is that patients who are re-challenged with a longer duration between stopping anti-EGFR and restarting it again did better. So patients need to have at least 6 months off an anti-EGFR agents before re-challenging them. So I think for me, for the majority of patients, I would probably go in with my first, second line chemotherapy, third line, probably Sunlight actually, and then fourth line in patients that remained ctDNA negative, go in with the anti-EGFR re-challenge, just so there's that really decent period off.
You're right. I retract my previous statement saying that there's only 3 agents in colorectal cancer. Maybe only 3 agents I know. But moving on from my own faux pas, Michael did want me to talk about neoadjuvant, and I will quickly get to that. But I think a lot of this also maybe hinders on, the role of ctDNA in something like colorectal cancer, because you can't keep biopsying a lesion every time it pops up when you progress. In your expert opinion, do you think it's going to become prime time soon? With the whole, if we are looking for regression and expression and those sorts of things and trying to really follow up sequencing and what options are, how do you see that playing, which is quite an expensive thing, doing ctDNA? Well, in Australia, it's very expensive, and probably in the UK it is as well. Sort of integrating that into your practice. Have you got any trials running, or what's your sort of experience with it?
I completely agree with you. It's not a straightforward thing to do. I think you've got two completely separate treatment settings. So you've got the early stage, and we'll maybe come back to that with the neoadjuvant, and the metastatic disease. And the main clinical applications right now is for anti-EGFR rechallenge. That's the place where there's the biggest evidence for doing a ctDNA in a patient. And arguably, that could be done at one time point for patients who are on their second line, third line treatment, and you're wanting to see if they're eligible for RAS-RAF anti-EGFR rechallenge. And that wouldn't be a huge amount of patients. Again, you would have to have ctDNA availability and drug availability in that setting. The other potential area at the moment would be actually hyperselection for anti-EGFR agents. But I've talked about epiregulin and amphiregulin, but there is something called the pressing panel using ctDNA, looking again for expanded mutations and very smaller clones that are associated with resistance. But in the UK, do we do this? No, we don't. It's not routinely rolled out. I don't know many countries where it's routinely rolled out. Portugal, I was over in Portugal recently, and they will do ctDNA at third line. So from country to country, even within the EU, it's very different in terms of the rollout and the cost implications and who pays for that. Is it the drug company who pays for it? Is it the payer, or for us, the NHS who pay for it? I completely agree with your point. And unfortunately, I think at the moment it will lead to inequity in access. And I think this is a big problem for the entire oncology community. In the MRD setting, we have far more trials running. Of course, Australia, in my view, have really led the way. Jeannie's work has been really fundamental in what we're doing, but are we ready to roll it out? Is NICE ready to approve a test yet? No. We're waiting with interest for Jeannie's data at ESMO, and we will see in the low-risk stage 3 population what the data looks like. But the stage 2 population, it hasn't shifted practice as yet. We have our ongoing trials. We have a trial called the TRACK trial, which is, again, looking at de-escalation in third line, in stage 3 patients. And so it's just going to be the point where the evidence accumulates sufficiently and the cost is acceptable for funders. But certainly we need, in the UK, randomised data. It needs to be very clear. We need to have good health economic data. So I think the situation for us is very different from the situation in the States, for example, where it is reimbursed and you can just order it. My question for them would be, well, what do you do with the result? Show me the data to not give chemotherapy to a patient who should have chemotherapy. Time will tell.
It's always interesting when we see some of the recommendations from the States where they're, by their own definition, at the bleeding edge. Maybe some might say too far beyond the bleeding edge because, as you say, they have all these wonderful tests. They say, brilliant, and then they don't really know what to do with it. We did want to shift to one of your other major areas of interest and expertise, Jenny, which is, I'm not going to commit the same faux pas as Josh, a very exciting emerging area of colon cancer treatment, which is the use of neoadjuvant. Obviously, other tumour streams, it's all shifting towards neoadjuvant, and through your work in the FOxTROT group, and there's the main FOxTROT trial, but I also saw that there's a bunch of other 5, if I'm not mistaken, that are planned or in rollout that is looking at this sort of almost chemotherapy sandwich for early stage colon cancer, which I thought was really interesting. And honestly, the thing that I was thinking when I was reading it was, this is something that seems so easy to sort of do in terms of clinical practice. It's amazing that it hasn't been trialed this much. But how did you get to that sort of stage of thinking about this and saying, well, what if we actually try this downstaging thing for colon?
Again, I have to say, the original FOxTROT trial, I think I was in medical school when that was first thought of by, again, Matt Seymour, my original mentor, and his surgical colleague, Dion Morton, who still works with me, who's a surgeon. And the key to neoadjuvant treatment in any cancer, but particularly for colon cancer, is this multidisciplinary team. It's not just about giving some chemotherapy. It's about identification of the patients that should have it by a CT scan, and it's about having a rapid turnaround of biopsy results to get an MSI or an MMR status. And then it's about oncologists treating patients quickly, because patients with a tumour in their colon can't be left for 4 weeks, 5 weeks, 6 weeks to start chemo. They need to be started chemo quickly. So again, it was Dion being a surgeon, seeing these patients with big bulky tumours, and Matt seeing it being rolled out in upper GI and other cancers. And so the FOxTROT trial it was really ahead of its time. And it was a very simple trial, just giving 3 cycles of planned chemotherapy ahead of surgery rather than all after surgery. Results were positive, led to a 5% reduction in the recurrence, and similarly for DFS. And you saw what you would expect. You saw downstaging. You saw the thing that surprised us, I think, when we got the results was actually surgical outcomes were better. And we were really worried that, all these patients were going to crash in their operation, but actually probably because the tumor was downstaged and because things like chemotherapy will improve your systemic inflammatory response. Actually, there were fewer perioperative complications. More people ever had chemo if you treated them at this point. So this was published, and alongside a couple of other trials have been published, and there was a recent meta-analysis using data from 4 other smaller trials. And the results are really convincing with this new meta-analysis. So I would urge people to go and have a look at that rather than, again, thinking about the idea 3 versus 6 months of chemotherapy. You usually need a meta-analysis in the early stage to really start shifting practice and convincing people. So that's where we started. So Dion lives in somewhere called Birmingham in the UK. And Matt and I got the train down to Birmingham to meet Dion one day. And we sat in the Birmingham rail station and thought, right, well, what are we going to do with these results now? And so over 2 hours, 3 hours actually, because Matt and I missed our train on the way home because we were having such a good conversation about it, we thought, right, well, what do we do next? People often think colon cancer isn't that bad. It's not as bad as pancreatic. It's not as bad as gastric. But it's still bad. There's still, if you look at 5-year overall survivals, there's still about 40% of patients stage 3 that will have recurrent disease. There's lots of room for improvement. I think there's a big shift of, number one, de-escalation with ctDNA. We're the kind of group going, no, we want to improve outcomes. Yeah, it's great to reduce the amount of chemotherapy that we're giving to people who don't need it. And that's a parallel, just as important research question. But at the same time, I think it's really important to then start saying, well, how do we cure more patients? And in my view, you're going to cure more patients by treating them quicker and by treating them in a more personalised manner. So completely different strands. And that's a big kind of debate within the colorectal community. Well, what is more important? And neither is more important, but it's about patient selection, number one. And that's the biggest challenge for colorectal, particularly colon cancer moving forward. How do you identify the high-risk patient baseline rather than on their post-op pathology, which is what we've always done. And so within FOxTROT, I can tell you a bit about the arms, but just as important in the trials is the parallel research that goes on. So we've talked about CRC stars, but we also have a parallel program in radiology trying to, number one, help radiologists actually look at the CT scan, because at the moment, quite often radiologists will look at a scan and say metastatic disease, yes, no, and they won't even comment on what the primary tumor looks like. So it's actually shifting, not just oncologists, not just surgeons, but trying to persuade radiologists to give a call on T stage and end stage, trying to get pathologists to give you your MSI results in a way that you can be able to act on them. It's not just the treatment, it's a huge machine in terms of the whole MDT. So yeah, that takes up quite a bit of my time.
I did want to ask about, I know you've written an article on the challenges and limitations of TNM staging. I was listening to the presentation and discussion of Atomic at the recent ASCO, and part of that discussion, and I think a discussion about neoadjuvant, you hinted at it, is this challenge of accurate staging without post-op pathology, and the challenges, as you say, for radiologists to sort of say, how big is this tumor? How far does it invade, based off scans and of gastroenterologist surgeons doing it off scopes as well. I thought that was an unexpected challenge for someone who likes their things simple.
So we just need to make it simple. This is it. So we just need to get data. We need to get evidence. So I'm a very close collaborator with Miriam Shalabi, who of course did the Niche 2 trial. And whilst I did FOxTROT, she was doing Niche 2. So we're actually presenting joint data of the FOxTROT trial and the Niche 2 trial at the oral session in ESMO this year. So what we're very clear about is that this is coming. The industry is super interested in the neoadjuvant setting. The data is getting more compelling. So the community just needs to move. In rectal cancer, it took 10, 15 years for this shift towards neoadjuvant treatment, but it did happen. And then so in colon cancer, it will happen. And it may just end up being the patients with the most advanced tumours that get neoadjuvant treatment. That's fine. So long as they get neoadjuvant treatment, then I'm happy. My concern is that because people are so concerned about over-treating patients, we're not treating those patients. So what a huge piece of our work is to try and actually move beyond TNM. So actually, if you imagine a luminal tumour, it's actually really hard to kind of put that in a T3 or a T4. So we're trying to look at alternative ways like actual measurements. And of course, AI is going to help amazingly with radiology. And if we can then give an AI program to a radiologist and it will come out with, measurements, and we can say, well, if you have this measurement, your risk of having problems is this, then I think we need to just help the whole team. ctDNA may well have a role in this. So in FOxTROT 3, we're going to be looking at how do you risk stratify patients? So the original staging, the measurements on radiology, the ctDNA, the pathology, and then you will look at that throughout treatment. So what happens to ctDNA during neoadjuvant treatment? What do you do with the people that don't respond? So there's an extremely rich research area. I have to say, in case any of your listeners are interested in this, there is very little going on in the neoadjuvant setting in Australia. So Neil Tebbett did try and get funding to join FOxTROT, but that was post-COVID and it was very difficult. So there's lots to do. I would encourage anyone who is interested in it to get on board, and I'd be very happy to hear from them.
Michael, aren't you the colorectal specialist at Princess Alexandra now?
You might have seen my hand just slowly inching up, Jenny, just saying, please pick me. If there's anything that is doable, because I'm just moving jobs, if there's anything that's doable, I will certainly hit you up because I would love to be involved.
But Michael, I'm sorry I threw you under the bus, but I had to.
I was just bouncing like, yes, absolutely.
Jenny, we always finish our podcast with the final question. It's sort of like the big hurrah for all of our incredible guests like yourself that come on board. You've shown that with this trial and everything you've kind of done, like the paradigm of moving oncology isn't just, a single person. It's a collaborative approach for everyone. But you've learned a lot of lessons along the way. The question we always ask everyone is like, if you could give your younger self some advice, whether that's personal, professional, just something when it comes to sort of how you've spent your last many years working and living, what would you tell yourself? Do you have any sort of like sage words of wisdom if you could ask yourself 20 years ago? It's like, this is what you should do.
You know what? Be bold. Be bold. There's been a couple of, you need to be less afraid to fail, because actually failure as such is part of research. If the results don't go your way, then that's important. If the grant doesn't go your way, that's what happens. You have to be bold. And I got that advice from a very wise person, Tim Mon, who is another GI oncologist. I got funding for the ARIEL trial and the FOxTROT trial at exactly the same time. I thought to myself, right, I'll put both of these in. One of them, there's no way both of them will be funded. And they were funded. And I thought to myself, can I do this? Then it comes down to, can we do this? Not ever can I do this, it's can we do this, but can I personally do this? I have 2 children. They were 8 and 4 at the time. I have other things going on in my life, but you can. And you can do this. And with the FOxTROT platform, I thought, right, we've got 2 things funded. Do I really want to start getting a BRAF targeted arm and an IO arm? Yes, you do. So be bold, ask the question, ask CRUK if they're interested in funding a translational program. Ask Matt Seymour if he's looking for a PhD student. Ask ESMO if you want to, be involved. None of these things have fallen on my lap. I have gone out and asked for them. And that's when I've been feeling it my most bold, but a part of me was like, oh my goodness, am I really doing this? So do it. What's the worst that can happen?
Wise words. What I like to say is a tour de force. Jenny, it's been absolutely brilliant. Thank you so much. It's been a lot of fun. Thank you for taking some time out of your very busy schedule. I can't think of a better way to end our interview. We really, really hope, if you'll be willing, that we'll have you back at some point. Grace us with your presence, please.
No, again, thank you for the invitation. It's been lovely and a lot of fun to speak to you.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.